including radon. Describe the 4 major histological forms of lung cancer and their biological behavior pattern relative to prognosis and therapy. Understanding the importance of distinguishing non-small cell carcinoma and small cell lung carcinoma. Okay. Describe the usual histological sequence of development lung cancer. Appreciate that the lung cancer arises through a series of molecular events. List the major cancer types associated with tobacco and discuss the role of smoking in the lung cancer. Describe major primary tumor of pleura and the environmental agent associated with it. Understand the role of smoking in asbestosis, including lung cancer and mesothelioma. So, in upper respiratory tract, there is a variety of non-neoplastic, also benign and malignant neoplasm of squamous epithelium and mesenchymal origin. Okay, so this is the there is some non-neoplastic and some are neoplastic. Like in non-neoplastic, we have nasal polyp, vocal cord nodule, benign nasal papilloma, laryngeal papilloma. Malignant, we have nasopharyngeal carcinoma and laryngeal carcinoma. So we start with the nasal polyp. It is non-neoplastic lesion. I give nasal polyp because it is most common. Okay, associated with inflammation and also allergy or mucoviscous, like in the cystic fibrosis. Also, it is soft polypoid mass that extend laterally from the mucosa into the anterior parts of middle meatus, usually some bilateral. With the time, they can fill the entire nasal cavity and extend upward into the cranial cavity. So what is the histological appearance? Is loose mucoid stroma, and you can see the mucus gland also covered by respiratory epithelium. Also, the stroma have inflammatory cells, lymphocyte, plasma cell, eosinophil, and mast cell. Usually, there is recurrent, okay, is a common, and following the surgical removal. So, probably because of the persistence of initiating pathogenic factors, like, because it is most of the nasal polyp is due to the allergic condition. So you can see this is the nose, and this is the polyp. Okay. So when you excise the polyp, it's like this polypoidal structure, and mostly have inflammatory, especially the eosinophil you can see, and mucus background. Can you see the also from the sinuses? This is the polyp. Awesome. Okay, second topic is nasopharyngeal carcinoma. It is strongly associated with the Epstein-Barr virus infection, and they said it is most frequent in the Chinese. But the APG genome, the viral oncogene, the tumor is not due to only anyone can expose to the Epstein-Barr virus can get the NPC, but also there may be the patient have also the genetic susceptibility, plus the Epstein-Barr virus infection can lead to the nasopharyngeal carcinoma. There is the WHO classification of the nasopharyngeal carcinoma. We have 3 types: keratinized squamous cell carcinoma, non-keratinized, which is undifferentiated, or we call dedifferentiated. This is the common type, and basaloid squamous cell carcinoma. Usually it's invade locally and spread to the lymph nodes, also have distant metastatic. By treatment is by radiosensitive, it is radiosensitive and 5-year survival in 50% of advanced. See, this is the tumor, you can see nest of tumor cells, you can see there, in with background of inflammatory cells there. Okay, so we can identify that it's a carcinoma. The cells are big with the prominent nucleoli. You can see this is another type. I mean, it can be either in the nest or mass of tumor cells, where rounded mass like this, or can be like diffuse mass or synovial, we call synovial pattern. But within the, can you see the cells? This is high NC ratio with the nuclei have prominent nucleoli, and within the tumor cells got the lymphocyte infiltrate. This one, the lymphocyte, the small one. Okay, okay, clear. So this is the APER immunohistochemistry for APER. APER is related to identify the Epstein-Barr virus. Okay, so you can see that this is tumor cells. They are positive to APER. That indicate this patient have Epstein-Barr virus infection. Okay. For vocal cord nodule, we call ACA single node. This is non-neoplastic lesion. It is a small hemispherical protrusion, usually less than 0.5 cm in diameter, most often located in the true vocal cord. Causes progressive hoarseness and never give rise to the cancer because it is non-neoplastic. Actually, it is occur in the patient who have chronic irritation due to smoking or due to abusing of the voice, like singers and also the teachers also. The histo fibrous tissue covered by stratified squamous mucosa. You can see this is the vocal cord and this is the nodule, small nodule. So the patient usually present with the hoarseness of voice. Okay. For the laryngeal carcinoma, is account only 2% of all cancers. Usually is in men more than women. Is the ratio is 7:1. It is associated with smoking, alcohol, asbestosis, radiation exposure. 95% are squamous cell carcinoma, rare adenocarcinoma. Most of laryngeal carcinoma is squamous cell carcinoma. The types of the tumor is according to the site of the tumor. We call glottic tumor, which is 60 to 75%, supraglottic 25 to 40%, subglottic is less than 5%. It's according to the site of the tumor, but the tumor is SCC. Okay, it is usually presented with persistent hoarseness of voice. Okay. Usually the supraglottic type rich in the lymphatic, so it will metastasize to cervical lymph node. Glottic interfere with vocal cord, so present early, okay, and spare the lymphatic, confined to the larynx. This is the kind of the presentation how it is present. In case of supraglottic, the patient usually presents with metastatic or lymph node enlargement, but in glottic, usually with hoarseness of voice. Subglottic usually present as advanced disease, usually already metastasized or okay. Treatment by surgery and radiation. The death is due to respiratory infection or widespread metastasis and cachexia. So you can see this is the vocal cord and this is the tumor, glottic, and also there. This is the tumor. This is the okay. This is the larynx. They already removed the larynx, and this is the tumor. Is the typical for squamous cell carcinoma, or gray whitish color with the cauliflower appearance, and it is here we can see nests of squamoid epithelium, and we can see this keratinization. Keratin. We call this keratinizing squamous cell carcinoma. Okay. Any question in the upper respiratory tract? We continue to the lower respiratory tract nebulosa. Any question on that? Hello? Hello?
No, doctor.
Okay. Is there any question on that side? On that part? Okay, we continue on lower respiratory tract nebulosa.
Doctor.
Yes.
The small nodules, right, in the vocal cord, how can you treat that? You can remove it or how?
Remove it. No, you mean the tumor or the...
No, the vocal cord, the small nodules, because it's just a small nodule.
Oh, the small nodule. Usually they remove it, the small nodule only. But if the tumor, they have to remove the all larynx. See?
I see, okay.
Okay.
Thank you, doctor.
Okay. Lower respiratory tract nebulosa. Lung cancer is the commonest cause of cancer death in advanced countries. The commonest visual malignancy in male peak incidence is 50 to 60 years. Usually poor prognosis, less than 50% 5-year survival due to lack of efficient diagnostic method for early detection, lack of successful treatment for metastasis. Disease, more than 75% patients present with stage 3 and 4. Most of lung cancer, usually the patients when discovered already in stage 3 and 4. Okay, advanced with the last decade, I mean the new recent method for the detection early tumor is better documentation of morphological change before development of clinical evidence like LIEF, laser-induced fluorescence endoscopy, which is a bronchoscopy, can localize pre-invasive and early invasive bronchial lesion. Low-dose spiral computed tomography, we can screen high-risk population, can diagnose a small peripheral tumor that are not seen in conventional X-ray. Sometimes you do the X-ray, you cannot see anything, but maybe with this advanced method, we can detect the early lesion like low-dose spiral computed. Anti-angiogenic chemo preventive agents also being have still in the study. Okay, for lower respiratory tract nebulosa, we have 90 to 95% are bronchogenic. Most of the lower respiratory tract is bronchogenic carcinoma. 5% bronchial carcinoid, 2 to 5% mesenchymal, and others. For bronchogenic carcinoma, according to WHO classification, we have squamous cell carcinoma, the commonest one, 25 to 40%. Adenocarcinoma have the same category, 25 to 40%. The others is small cell carcinoma, 20 to 25%. Large cell, 10 to 15%. Mixed pattern is not infrequent. For clinical course, how the patient presented in or have the lung cancer. Okay, the first symptom is we have the cough. Most of the patients have cough. then also weight loss in the term of cachexia. Okay, and also chest pain. 40% of patients they have chest pain. Dyspnea, 20% of them, and hemoptysis. I mean, not all the lung cancer have hemoptysis. Okay, sometimes they just have cough, weight loss. Okay, and some of them they have just chest pain and dyspnea, cough. The usually increased sputum production containing tumor cells. So we can detect the tumor cells by investigation of the sputum. For cytology, you can see some malignant cells inside the sputum. Focal emphysema, atelectasis, and bronchiectasis, pulmonary abscess. Have you remembered our class before 2 days? The bronchiectasis is not a primary disease, it's due to secondary to the other disease like cancer when there is obstruction also. So the lung cancer may have the patient have emphysema because of the obstruction actually. Also atelectasis, also due to obstruction. Bronchiectasis, also when there is obstruction, it leads to the infection to proliferate the infectious agent. Also pulmonary abscess, if there is infection with obstruction, can lead to the pulmonary abscess. This is one of the presentation or sometimes the complication of lung cancer. We have superior vena cava syndrome when the tumor invade the vena cava. Pericarditis, pleuritis, when the tumor is invade the pleural cavity or pleura, and also the pericardium. Horner syndrome. Horner syndrome is usually associated with the adeno-CA because this arises in the apex, and when it is the tumor in the apex, it invades the sympathetic ganglia, so it causes Horner syndrome. So we call this pancreatic tumor. So sometimes the patient have Horner syndrome. So in this case, we have to investigate whether he has lung cancer or not, because sometimes in the adeno-CA, the patient usually have Horner syndrome. Paraneoplastic syndrome, if you can remember paraneoplastic syndrome, maybe patients usually have features of Cushing syndrome like ACTH, and also all patients have hypercalcemia or patients have hyponatremia, and we just try to treat, but we don't know there is actually the pre-existing tumor in the lung. So we have to investigate also usually lung for the ectopic secretion of the tumor for these hormones. Okay, sometimes patients have Horner syndrome, hoarseness of voice, due to the tumor is invade the recurrent laryngeal nerve. Okay, understood. So this is the presentation of the tumor. Sometimes they present with this complication of the tumor before they discover the tumor. So what are these?
Clubbing.
Yeah, clubbing. So the patient, one of the features also clubbing of finger. Okay, what is the premalignant lesion? We have angiogenic squamous dysplasia carcinoma in situ. So we can detect through LIFE. Atypical alveolar hyperplasia is a potential precursor for adenocarcinoma. Can be detected with a spiral CT scan. Diffuse idiopathic neuroendocrine cell hyperplasia, not shown to be related to small cell carcinoma, possible small carcinoid tumor. Okay, so we can see this is by LEF. Can see they can detect the small, very small lesion. Okay, small lesion there. See, can you see there? This is a lesion there. This is the tumor. The early, the early changes of the tumor can be detected by the immunofluorescence. This is by spiral CT scan. You can see the very small. You can see this very small lesion there. Okay. So, if you remember the dysplasia, when the patient have chronic smoker, most of the tumor bronchogenic carcinoma usually is associated with the smoking. Okay, so initially there is squamous metaplasia from columnar to squamous. So when we ask how there is squamous cell carcinoma, even the bronchial lining is columnar. This is actually arise on the top of the squamous metaplasia due to chronic irritation. So the columnar will be transformed into stratified squamous epithelium. So with prolonged use of tobacco smoking, it leads to the dysplasia, right? From mild to moderate to severe. Severe when is involve the full thickness of the epithelium. After that, if the patient stops smoking, it will lead to the invasive squamous cell carcinoma, right? Before we go to the morphology of the lung cancer, we need to review the multi-step carcinogenesis. Remember in GPAT, 4 genes, isn't it? Multi-step process usually occur in sequelae of genetic cellular changes, result in formation of invasive tumor. So it is usually caused by chronic exposure to tobacco carcinogen. Then after that, oncogene activated via point mutation, gene amplification or chromosome rearrangement, tumor suppressor gene also inactivated by loss of one parental allele, mutation. Okay. Also, they said DNA repair gene is not prominent in this cancer, but mostly is implicated is tumor suppressor gene and also oncogene. This one activation and inactivation is due to the tobacco smoking, because the tobacco carcinogen, the cigarette smoke contain about 10,000 of different carcinogenesis. Okay, so role of tobacco smoking is with the statistical evidence, it is depend on the amount of daily smoking. Okay, tendency to inhale, duration of smoking habits, and I mean how many smoking, those who is heavy smokers and also long term of smoking about 10 or 20 years, they have the risk for developing cancer. And also tendency to inhale means some people, they are not the passive smokers have the same risk those with active smoker. And also some people have tendency, maybe tendency for the effect for the smoking. I mean, is varies from person to person. Some people, the cigarette smoking affect and causes the cancer, and some of them little effect. It takes long term for smoking. So the smoker have tenfold increased risk than non-smokers. Okay, so the heavy smoker is considered 40 cigarettes. Okay, with these through 7 years have 20-fold to increase risk for developing cancer. Also, the cigarette smoking not only implicated in the lung cancer, it also cause cancer lip, tongue, floor of mouth, pharynx, larynx, esophagus, urinary bladder, pancreas, and kidney. Okay. They found 95%, 96.7% of cigarette smokers showed some atypical cells in the bronchial tree. For how they said the rule of tobacco, they have this is the rule: initiator, promoters, and radioactive. Initiators like polycyclic aromatic hydrocarbon, benzopyrene, promoter phenols, derivative, radioactive elements, which is contaminated, mold, addictive. How the initiator means it can causes mutation in the DNA, and we said activate the proto-oncogene, and also suppressor, tumor suppressor gene is inactivated. Promoter promoter means if there is pre-existing tumor, it will accelerate the tumor to progress. Okay, plus the radioactive elements also can, same things, causes mutation of the DNA, the radioactive. Okay, the nicotine is not a carcinogen, you know. We said many people, they thinking about that nicotine is the carcinogenic part. No, it is considered it is addictive. This is causes addiction to the cigarette smoke. But maybe they said it can mutate and also inhibit apoptosis, and if there is a tumor, it can accelerate the existing tumor. But the initial, I mean, carcinogen is the polyhydrocarbon and also phenol derivatives and the radioactive parts. Understood? Hello?
Yes, doctor.
Okay. Other industrial hazard, radiation, like survivor in Hiroshima and Nagasaki atom blast. Also, non-smoking uranium minerals, 4-fold increased risk. Non-smoking asbestosis, those who working in the asbestosis worker, 5-fold increased risk. Also, see the asbestosis also in lung cancer and implicated in the pleural cancer, mesothelioma. So it's implicated in both in mesothelioma and the bronchogenic carcinoma. Those smoking plus asbestosis together workers is 50%. I mean 50-fold increase for breast cancer. See, if asbestosis alone 5-fold, but if with smoking it's increased 50-fold for developing cancer. Okay. Other rules of air radiation like atmosphere, air pollution, radon, or radioactive gas, role of genetic factor. Occasional familial cluster suggest genetic predisposition. KRAS in adeno-CA-CROYC in small cell carcinoma, loss of also P53. Exposure to tobacco, industrial hazard, air pollution ultimately cause genetic alteration in the lung. Okay, so usually most of the people, they not only exposed to tobacco, to other industrial, so altogether with genetic, all this can lead to the development of the lung cancer. Okay. So the gross, usually they said 75% of the bronchogenic carcinoma is arise from the first, second, and third order bronchi. Okay, the small number is arise from the periphery, especially from the alveolar septa or terminal bronchioles, mainly adenocarcinoma. We said most of adenocarcinoma are in the periphery, isn't it, in the apex. In situ, regular warty experience in the epithelium, the invasive usually fungating into the bronchial wall or penetrate the bronchial wall to infiltrate the peribronchial tissue. Okay, or it can be appear as cauliflower-like intraparenchymal mass, usually extend to pleural lymph node and causes distant metastatic. You can see here, this is the bronchial, this is the hilar area, and this is the tumor is arises from the bronchial wall. You can see those small, can you see those? The bronchial tree is actually the tumor arise from this, and you can see the black color is actually, this is the indicate the patient, this patient is heavy smoker. You can see the smoking there, and this is the tumor within inside the bronchial wall. This is the squamous cell carcinoma with cavitary lesion. Is look like that TV. You can see this is the squamous cell carcinoma already invading the pleural, okay, with gray whitish tumor, okay, and invading the pleura and also to the surrounding the alveolar tissue. This is the bronchi, it is arising from the bronchial wall. Okay, for adeno-CA, usually in the periphery, we said at the periphery, at the apex. Usually, most of the adenocarcinoma is associated with the, or we said, they can present with Horner syndrome because they can invade the sympathetic ganglia and causes Horner syndrome. In this case, we call pancreatic tumor. Okay, and also they arise from the, also still from the bronchial wall, okay, especially the small bronchioles. Bronchoalveolar carcinoma usually, can you see those small, it's like pneumonia, like consolidation. Actually, it is due, arising, is not in the hilum. In the hilum, most of the in the hilum, hilar area is the squamous cell carcinoma and small cell carcinoma. Adeno-CA at the periphery. Bronchoalveolar carcinoma usually distributed all over the lung. It is look like the pneumonia consolidation. Okay, the histology or here microscopic features. Squamous cell carcinoma, most of the squamous cell carcinoma is in main and closely related to the smoker. Okay, larger, more central bronchi. Why it is present in the hilar area? Because in central bronchi, and they can metastasize later. They can grow with cauliflower. It is well differentiated, produce keratin and desmosome. Poorly differentiated, usually merged to the undifferentiated large cell type. You can see this is the cytology when we talk the bronchial lavage. You can see this is the squamous cells and high NC ratio. If we see this kind of cells, we consider as malignant. Okay, this is histo. We can see this is the tumor with large polyhedral cells with high NC ratio and prominent nucleoli. You can see between the cells there is intercellular bridge. This one, okay, or in desmosome, it's the same things. Okay, this is well differentiated. If we see like this, and there is a desmosome and intercellular bridge, is indicate well differentiated. And also presence of keratin perk We see abundant keratin pearls, that means this is well differentiated. When there is less, 50% keratin pearl is moderately. If there is no, a little bit occasionally and just only like these cells, we call this poorly differentiated. Okay, for adenocarcinoma, bronchial derived, she is from bronchial, okay, and it is in the form of acinar, papillary, or solid, okay. Bronchoalveolar, usually the adeno-CA, they said, is a woman, occur mostly in the woman, and they are non-smoker. So the adeno-CA sometimes is not related to smoking, okay, and they think it is maybe due to the p53 mutation, which is a tumor suppressor gene. And most of the adeno-CA are located at periphery, okay, and most of them, 80%, they contain mucin. You can see this is the cytology of the bronchoalveolar lavage. You can see like a papillary, isn't it? Papillary, and contain the cells. If you see the high irregular nuclei there, and got mucin. Once we see this kind of cells, we report as malignant, okay, and suggestive of adeno-CA. So in biopsy, we can see the malignant gland. Can you see very well differentiated? You can see the malignant gland there invading the lung, and they are lined by columnar malignant cells, high in C ratio. Can you see? This is also malignant gland. You can see there, and here is a necrosis. Okay, this is bronchoalveolar carcinoma. We can see from the arising from the alveolar wall. Can you see? Bronchoalveolar, both. Okay, you can see like papillary protrusion to the lumen. Okay, with they are lined by columnar malignant cell with high NC ratio. Okay, and this is the normal alveolar wall. This one is when the lung cancer metastasized to brain, so we can see multiple lesion in the brain. This is metastasized from lung cancer. Small cell carcinoma. Do you want to rest, break, or we can continue? Hello? Hello?
Saying break, doctor.
You want break?
Dr. Bushra, can you go back to the slide of the alveolar slide?
This one?
Yeah. So both of these is abnormal, or the right one is normal?
This one is normal. You can see the alveolar wall, but here you can see the tumor there is arising there.
Oh, okay. So the right picture is carcinoma.
Which one? This both carcinoma.
Yeah. Right picture.
Yeah, but here you can see, just to compare the normal area. Okay, you can see they are lined by pneumocyte 1 and 2, isn't it? And here there is a tumor actually.
Okay, thank you.
So I can give you break 5 minutes. Okay, then we continue.
Okay, doctor.
Hello?
Yes, doctor, we can hear you.
Yeah, we can continue.
Yes.
For small cell carcinoma, usually the small cell carcinoma is highly malignant. We call the classical one is oat cells. It's like oat cells, oat, small, very small, or small blue round cell tumor. It is round to oval, about 2 to 3 fold size of lymphocyte. Okay, why we show that? Because it has the scanty cytoplasm and round nuclei, and why we call blue round cell, because the cytoplasm is very scanty. So the most of the nuclei occupying the cytoplasm. And other features is nuclear molding. Nuclear molding means the cells are facing each other. Can be spindle or polygonal small cell carcinoma. It is derived from neuroendocrine cells of lining bronchial epithelium. So why it is sometimes associated with paraneoplastic syndrome like Cushing syndrome, because it is rise from neuroendocrine cells. For the electron microscope, we can see dense core neurosecretory granule. This is to give the evidence that it is arise from neuroendocrine. Okay. Also has ability to secrete polypeptide hormone. Also, a neuroendocrine marker like NSE and chromogranin is positive in the small cell carcinoma. Okay. Usually, most of the small cell carcinomas are strongly associated with the cigarette smoking. So, most aggressive metastasize widely often in the hilar, central, or ventrally incurable by surgical means. Ectopic hormone production also is associated with this tumor. Its response to chemotherapy. Sometimes, the patient is present with metastatic lesion, before they discover the primary tumor. So it is highly aggressive. Once we diagnose small cell carcinoma, we have to report to the surgeon, because it is highly aggressive and it is doubling, everyday doubling. So it can be metastasized easily. So you can see this is a small cells. We call blue round cells, because when we look at the tumor is like blue. Okay, round cells, small, round, they are small cells, look like the bigger than the lymphocyte, and they have scanty cytoplasm, and most of the cells are occupied by nuclei and darkly stained nuclei. So we said nuclear molding. Can you see the nuclear molding? The nuclei are facing each other. This is nuclear molding. Okay, see, look. This is nuclear molding there. Okay. Large cell carcinoma, it is anaplastic large polygonal cells with vesicular nuclei. Probably represents squamous or adenocarcinoma that are also undifferentiated, giant cell, clear cell, and spindle cells. When we see like this kind of cells, There is no squamous differentiation, no gland differentiation, and the cells are large with this kind of defect and abundant cytoplasm. In this case, either we report large cell carcinoma or undifferentiated squamous or adeno, because undifferentiated squamous cell carcinoma and also adeno is look like this large cells. So in this case, we have to do the stain to know whether it is adeno or squamous or large cell. Okay, this is the staging. No need to go through it, just to know, nice to know all these things. For pleural tumor, metastatic involved is far from the common than primary tumor. I mean, the primary tumor is not a common. So most of the pleural tumor is due to metastatic from other side. For primary tumor, we have pleural fibroma, which is very rare, and malignant mesothelioma. So what is the malignant mesothelioma? It is associated with heavy exposure to the asbestosis. Is a risk for the tumor, and it's about 7 to 10%. Okay, long period of 25 to 40 years, no increase in risk in the worker who smoke. No, the asbestosis is related to bronchogenic carcinoma as well, and the risk is markedly magnified by smoking. Okay. What is the clinical features? Usually patients have chest pain, dyspnea, recurrent pleural effusion. Direct invasion of the lung, hilar node metastasis, and also distant metastasis. Concurrent with pulmoasbestosis in 20% of patients, and it has poor prognosis. See, the mesothelioma is not common. It is common in the industrial countries. Okay. The gross diffuse lesion in pleural space is associated with extensive pleural effusion. Direct invasion for thoracic structure affected. The lung is usually like covered or initiated by a thick layer of soft gelatinous gray whitish pink tumor. The histology have 3 types: sarcomatoid, epithelial, and mixed. It has a mixture of 2 types we call biphasic, either sarcomatoid type or epithelial, or we can either sarcomatoid or epithelial or both. Okay. So how can the epithelioid mesothelioma be distinguished from adeno-CA? Because evidence information would be diagnostic of adeno-CA. Also, by electron microscope, we can see the branching microvilli is a characteristic of mesothelioma. Also, a large number of the cell surface and cytoplasmic antigen are considered to be diagnostic useful, but none is totally specific. We have to do also the immunohistochemistry to differentiate between the mesothelioma and adeno-CA. So you can see this is the tumor is like nodular tumor, and also there can you see is usually if there is mesothelioma is like the lung is covered by this sheet of the nodular tumor. You can see here there are 2 types. This is monophasic, which is sarcomatoid part. You can see spindle tumor. Here we have both, which is 2 physics. Biphasic, we said glandular. This is the glands, and also the sarcomatoid part. The glands also lined by malignant mesothelial cells. And in this case, maybe we are mistaken with adeno-CA, but we have to do a panel of the immunohistochemistry to differentiate between adenocarcinoma of bronchogenic type or mesothelioma of pleura. Okay, that's all. Any question? Hello?
Doctor, so mesothelioma only happens in the pleural, right?
Yeah, in pleura. It's a tumor of pleural. But it can invade the lung tissue. So even sometimes when we do the bronchoalveolar lavage, you can see the malignant mesothelial cells. They have microvilli. Okay. This one. This is a tumor of pleura. Can you see? This is the pleura, and this is the tumor. This is the lung. Okay. And they covering the lung with this tumor. But it is rare tumor. I didn't see a lot in Malaysia. Any question? Hello?
Doctor, I'll send the attendance.
Okay. The rest maybe they are asleep. I don't know. I feel I'm talking with you only. The rest are sleeping.
Doctor. Hello? Doctor?
Yep. Yep.
Doctor, can you send the lectures on Teams?
Okay.
Thank you.
You don't have this, is it?
I don't know for everyone else, but I don't have.
Okay. I will put it in the team, okay?
Okay, thank you.
Okay. Okay.
Doctor.
Yep.
So if you want to differentiate mesothelioma with the adenocarcinoma, we must do the immunohistochemistry, is it?
Yeah. Actually, not electron microscope, because the nice is to do the electron microscope, isn't it? To see the microvilli, but not. I mean, not all the labs they do it. They have the electron microscope. So they have just done the mucin. Usually mucin is positive in adeno-CA. We can see mucin. And the other immunohistochemistry like CK7 and CK20, other many panels, we do it to differentiate between both. Okay.
All right, doctor.
And also, you know, the what we call the clinical correlation. We ask whether there is pleural effusion, because most of the adeno, they don't have pleural effusion unless if invading the pleura. If they invade pleura, in this case, difficult to differentiate. But if the tumor primary from the pleura, this is favor the mesothelioma. And also, if cover most of the pleura, that means is mesothelioma. Plus, sometimes they give this kind of sarcomatoid appearance. Is not present in the adeno-CA. Okay. Is there any question? Another question? Hmm? So no more questions? No more questions? So
I think no, doctor.
no. Okay. So I can end my class. Okay. So okay. See you when in Himato.
Bye-bye, doctor. Thank you.
Bye.
Thank you, doctor.
Thank you,
Himato
doctor.
Hamsun.
Thank you, doctor.
Bye.